In this presentation, we will explore the pathophysiology of disseminated intravascular coagulation, or DIC. DIC is a complex condition characterized by abnormal and widespread activation of blood clotting within the body. In this section, we will first discuss sepsis-induced coagulopathy, or SIC, and then move on to disseminated intravascular coagulation, or DIC. Hemostasis is maintained by three core systems that work in balance. The procoagulant system promotes clot formation to stop bleeding. The anticoagulant system limits excessive clotting and prevents thrombosis. The fibrinolytic system breaks down clots through the action of plasmid. Under normal conditions, these three systems remain tightly regulated and balanced. This diagram illustrates the coagulation cascade, which consists of two initiating pathways, the intrinsic pathway and the extrinsic pathway. The intrinsic pathway, also known as the contact activation pathway, begins when blood comes into contact with a damaged or negatively charged surface. This leads to activation of factor 12-2-XIIA, factor XIIA, then activates factor 11-Shia, which subsequently activates factor IX2-IXA, factor IXA, together with its cofactor factor VIII, forms a complex that activates factor X. In contrast, the extrinsic pathway is triggered by tissue injury. Trauma exposes tissue factor, which binds to factor 7 and converts it into VIA. The tissue factor VIA complex directly activates factor 10. Both intrinsic and extrinsic pathways converge at the activation of factor X to factor XA. Factor XA, together with factor VA, forms the prothrombinous complex, which converts prothrombin or factor 2 into thrombin, also known as factor IEA. Thrombin plays a central and critical role in it converts fibrinogen into fibrin monomers, which polymerize to form a fibrin network. Thrombin also activates factor 13-2-XIIA, which cross-links fibrin and stabilizes the clot. In addition, thrombin amplifies the cascade by activating factors V8 and Xi, creating a positive feedback loop. Under normal conditions, coagulation is tightly regulated. Thrombin binds to thrombomodulin on endothelial cells, which activates protein C. Activated protein C, together with protein S, inactivates factors VA and VIA, thereby limiting further thrombin generation. This balance between procoagulant activity and anticoagulant control ensures that clotting remains localized and controlled. This slide illustrates the fibrinolytic system, which is responsible for breaking down fibrin clots. The central component of this system is plasminogen, an inactive precursor circulating in plasma. Plasminogen is converted into its active form, plasminogen activators. The most important activator is tissue plasminogen activator, or TPA, which is released from endothelial cells. Urokinase is another activator that can also convert plasminogen into In addition, factors from the intrinsic coagulation pathway, such as factor XIAA, factor XIIA, and kallikrein, can also promote plasmin generation. Once activated, plasmin degrades fibrin into fibrin degradation products. These degradation products include dimers, which are clinically used as markers of fibrin breakdown and ongoing coagulation activity. This process ensures that clots are removed after they have fulfilled their function, preventing excessive thrombosis. Therefore, fibrinolysis serves as a physiological counterbalance to coagulation.
The fibrinolytic system is tightly regulated by several inhibitors. Plasmin activity is inhibited by alpha-2 antiplasmin and alpha-2 macroglobulin, which neutralize circulating plasmin. Plasminogen activators such as TPA are inhibited by plasminogen activator inhibitor 1 and inhibitor 2, known as PAI1 and PAI2. In addition, thrombin activates thrombin activatable fibrinolysis inhibitor, or TAFI, which suppresses fibrinolysis. Under normal conditions, this balance prevents both excessive clot formation and excessive bleeding. During sepsis, the inflammatory response profoundly disrupts the balance between coagulation and anticoagulation, leading to excessive thrombin generation and microvascular thrombosis. Pathogen-associated molecular patterns, PAMPS, from invading microorganisms and damage-associated molecular patterns, DAMPS, released from injured host cells, activate monocytes, neutrophils, platelets, and endothelial cells through pattern recognition receptors, such as toll-like receptors. This inflammatory signaling induces the release of cytokines including TNF-alpha and IL-1-beta, which upregulate tissue factor, TF, expression on circulating monocytes and endothelial cells. Under normal conditions, tissue factor is not exposed to circulating blood, but during sepsis, its widespread expression initiates the extrinsic coagulation pathway. Tissue factor binds to factor 7A, forming the TF-F7A complex, which activates factor 10 to 10A and factor 9 to 9A. Factor 10A, together with its cofactor factor 5A, forms the prothrombinase complex on phospholipid surfaces, particularly activated platelets, converting prothrombin into thrombin. Initially, only small amounts of thrombin are generated. However, thrombin rapidly amplifies its own production through positive feedback mechanisms by activating factors 5, 8, and 11. Activation of factor 8 and factor 9 enhances formation of the tennis complex, FIXA to F8A, which further accelerates factor 10 activation. This results in an explosive thrombin burst, a hallmark of septic coagulopathy. At the same time, neutrophils contribute to coagulation through the release of neutrophil extracellular traps, nets, which are networks of extracellular DNA decorated with histones and proteolytic enzymes. Nets provide a procoagulant surface that activates factor 12, thereby triggering the intrinsic pathway. Histones themselves are cytotoxic to endothelial cells and possess direct procoagulant properties. Nets also trap platelets and red blood cells, stabilize fibrin, and promote microthrombus formation. Endothelial dysfunction is another central component of sepsis-induced coagulation. Inflammatory injury causes endothelial cells to lose their anticoagulant phenotype. There is decreased expression of thrombomodulin and endothelial protein C receptor, resulting in impaired activation of protein C. Levels of natural anticoagulants, such as antithrombin and protein C, are reduced. Simultaneously, endothelial cells release von Willebrand factor from Weibel pallade bodies, enhancing platelet adhesion and aggregation. The net effect is a shift toward a strongly prothrombotic state. Thrombin itself further links coagulation and inflammation. Beyond converting fibrinogen to fibrin, thrombin activates platelets via protease-activated receptors, PARS, and stimulates additional inflammatory signaling. Thus, coagulation and inflammation amplify each other in a vicious cycle. Ultimately, this uncontrolled thrombin generation leads to diffuse fibrin deposition within the microvasculature, impaired tissue perfusion, organ dysfunction, and, in severe cases, disseminated intravascular coagulation, DIC. This slide compares the antithrombotic capacity of the endothelium under physiological conditions with what happens during sepsis-induced coagulopathy, SIC. The upper half represents the healthy state, while the lower half illustrates the pathological changes occurring during sepsis. Under normal physiological conditions, the vascular endothelium maintains a strongly antithrombotic surface. The endothelial glycocalyx forms a protective barrier that prevents direct contact between circulating blood cells and the vessel wall. Endothelial cells produce nitric oxide, NO, and prostacyclin, PGI2, which inhibit platelet activation and promote vasodilation. Heparin sulfate expressed on the endothelial surface enhances the activity of antithrombin, which inhibits thrombin and factor XA. Thrombomodulin, TM, binds thrombin and converts it from a procoagulant enzyme into an activator of protein C. Activated protein C, APC, together with its cofactor protein S, inactivates factors VA and 8A, thereby limiting further thrombin generation. Altogether, these mechanisms maintain blood fluidity and prevent inappropriate clot formation. In contrast, during sepsis-induced coagulopathy, this protective system is profoundly disrupted. Inflammatory cytokines damage the endothelial glycocalyx and reduce the production of NO and PGI2. Thrombomodulin expression decreases, and soluble thrombomodulin, STM, may be released into circulation, reflecting endothelial injury. As a result, activation of protein C is impaired, weakening a major anticoagulant pathway. At the same time, procoagulant mechanisms are upregulated. Monocytes and endothelial cells express tissue factor, which initiates the coagulation cascade and promotes thrombin generation. Neutrophils release neutrophil extracellular traps, nets, which provide a scaffold for fibrin deposition and further activate coagulation. Thrombin levels increase significantly, converting fibrinogen into fibrin and amplifying clot formation. Platelets become activated and interact with von Willebrand factor, VWF, which is released in large amounts from endothelial Weibel pallid bodies. Adhesion molecules are upregulated, promoting platelet leukocyte aggregation and thrombus formation. Additionally, fibrinolysis is suppressed. Plasminogen activator inhibitor 1, PAI1, levels increase, reducing the breakdown of fibrin clots. Angiopoietin 2, ANG2, contributes to endothelial destabilization and vascular leakage. The combined effect is microvascular thrombosis, increased vascular permeability, and impaired tissue perfusion. Overall, the slide illustrates a fundamental shift in sepsis from a balanced anticoagulant endothelial phenotype to a prothrombotic, inflammatory, and dysfunctional state, which contributes to organ failure and the progression toward disseminated intravascular coagulation. This slide illustrates the pathophysiology of thrombocytopenia in disseminated intravascular coagulation, DIC, particularly in the context of sepsis. It highlights the multiple mechanisms that contribute to a reduced platelet count during severe infection. The process begins with infection, which triggers a systemic inflammatory response. In sepsis, inflammatory cytokines and microbial products activate immune cells, endothelial cells, and platelets. This widespread activation leads to several parallel mechanisms that reduce platelet numbers. First, decreased platelet production occurs at the bone marrow level. Inflammatory mediators suppress megakaryocyte maturation and platelet production. Bone marrow dysfunction, hypoxia, and direct toxic effects of cytokines impair thrombopoiesis. Although thrombopoietin, TPO, levels may increase, the response is often insufficient to compensate for accelerated platelet consumption. Second, there is increased platelet consumption due to thrombosis. In DIC, systemic activation of coagulation leads to excessive thrombin generation. Thrombin activates platelets, which aggregate and become incorporated into widespread microvascular thrombi. This consumptive coagulopathy results in progressive platelet depletion. Third, increased platelet destruction contributes to thrombocytopenia. Activated platelets interact with neutrophils and monocytes, forming platelet leukocyte aggregates. Neutrophil extracellular traps, NETs, further trap and activate platelets. Inflammatory and immune-mediated mechanisms may also enhance platelet clearance by macrophages in the spleen and liver. Fourth, increased platelet sequestration occurs, particularly in organs such as the spleen and lungs. In sepsis, altered microcirculation and endothelial activation promote platelet trapping within inflamed tissues and microthrombi, effectively removing them from circulation. the slide also emphasizes the dual role of platelets. Beyond hemostasis, platelets have antimicrobial and pro-inflammatory functions. They release cytokines, chemokines, and reactive oxygen species, and interact with leukocytes to enhance immune responses. While this contributes to host defense, it also accelerates platelet activation and consumption. Finally, the lower section of the slide refers to potential treatment strategies in ICU management. Some interventions, such as platelet transfusion, intravenous immunoglobulin, IVIG, thrombopoietin receptor agonists, and cytokine modulation, have varying levels of supporting evidence, strong versus weak data. However, the cornerstone of management remains treating the underlying infection and controlling sepsis. In summary, thrombocytopenia in DIC is multifactorial. It results from decreased production, increased consumption through systemic coagulation, enhanced destruction via immune mechanisms, and increased sequestration in organs. This complex interplay explains why low platelet counts are common and clinically significant in septic patients with DIC. This slide summarizes the core pathophysiology of disseminated intravascular coagulation, DIC, emphasizing three major processes: pathologic thrombin generation, impaired natural anticoagulant mechanisms, and dysregulated fibrinolysis. Together, these mechanisms explain why DIC is characterized by both thrombosis and bleeding. First, DIC is driven by excessive and uncontrolled thrombin generation. The process is usually initiated by tissue factor, TF exposure, which forms a complex with factor 7A. This complex activates factor 10 to 10A and factor 9 to 9A. Factor SA, together with its cofactor factor VA, forms the prothrombinase complex, converting prothrombin into thrombin. Thrombin then amplifies coagulation by activating factors V, A, and EN, creating a powerful positive feedback loop. It also activates platelets and converts fibrinogen into fibrin. Factor 13 stabilizes fibrin by cross-linking it, forming insoluble cross-linked fibrin clots. This leads to widespread microvascular thrombosis. Second, natural anticoagulant systems become impaired. Under normal conditions, coagulation is tightly regulated by three main anticoagulant pathways: tissue factor pathway inhibitor, TFPI, the protein C system, and antithrombin, AT3. In DIC, these systems are suppressed or depleted. Protein C levels decrease due to impaired activation and increased consumption. Antithrombin is consumed by binding to excessive thrombin and factor XA. TFPI activity is reduced. The loss of these regulatory mechanisms removes the physiological brake on coagulation, further promoting thrombosis. Third, fibrinolysis becomes dysregulated. Plasmin normally breaks down fibrin into fibrin degradation products, FDPS, including D-dimer. In early DIC, plasmin activity may increase, contributing to bleeding. However, in many cases, especially sepsis-associated DIC, there is excess production of plasminogen activator inhibitor 1, PAI1, which suppresses plasmin generation. This leads to fibrinolytic shutdown and persistent fibrin deposition, promoting thrombosis. At the same time, alpha-2 antiplasmin, the natural inhibitor of plasmin, may become depleted. When this occurs, unchecked plasmin activity can excessively degrade fibrin and clotting factors, contributing to bleeding. Therefore, DIC represents a paradoxical state in which both clot formation and bleeding occur simultaneously. In summary, DIC results from uncontrolled thrombin generation, depletion of natural anticoagulants, and imbalance of fibrinolysis. The combined effect is widespread microvascular thrombosis leading to organ dysfunction, along with consumption of platelets and coagulation factors that predisposes to bleeding.